Good morning. My name is Denise Cooper, and I work as the Vice President of Special Initiatives for Nearform.
And hi, I'm Críosta. I'm the product manager for the COVID Tracker app released by the Health Service Executive in Ireland.
And we're going to talk today about the data that our app collects and what we do with it. But first, I really have to congratulate you, Gar, on the amazing response we've seen in Ireland to the app. So tell me, how many people have installed it today?
So as of this morning, there's 1.3 million people and change have installed and configured the app. So they're up and running and protecting each other, which has been an amazing start.
Yeah, boy, I know we were so nervous. But what would you say was the most important things you did? Because if you don't have adoption, you have no data.
Agreed. I think it's important to note that the starting point for this was the public health response overall. So prior to the app, prior to any idea of the app, the public health response to COVID-19 was received with, I guess, a great degree of acceptance from the public. And there was a great degree of trust built between the Health Service, the Department of Health, the HSE, and the overall Irish government response to this had built trust within the population to the response and the response efforts, and that the government were trying to do the right things. And I think that was the starting point for it. And various people and faces popped up. So Tony Holohan was the chief medical officer. He he was kind of the face of COVID-19, and he was that trusted, authoritative voice. And I think it was a critical foundational piece to this, even before we got to talking about building an app or doing digital contact tracing or how we would do anything like that.
Right, because trust is the whole thing. Now, I know that there was some initial problems with the media.
Yeah, I was actually looking back on my Twitter feed, and I think the initial calls for transparency happened on the fourth day, for me, the fourth day into this initiative back in March. So, and at that point in time, we were actually, I don't think we'd even started working with Nearform at that point in time. So it was hinted at that we were looking at building an app, and there was an immediate call for tell us what you're doing. And at that point in time, we were looking around for solutions to try and understand how we would do contact tracing. I think looking at it now, it all seems very obvious that Bluetooth-based proximity or proximity-based contact tracing was the way to go. But back then, we were looking at would we use geo data? Would we use GPS data from phones? Would we use data from telcos? Would we use data from ad identities? There was a lot of potential options there at that point in time, and I think if that created well, for us, we're trying to figure out a problem, but from the outside in, the observer on the outside is looking very much for tell me what you're going to do. And when you don't have a good answer to that question, it's a very difficult situation to be in, because you're now looking at it. I think for anybody starting now, the answer is pretty obvious. We've kind of coalesced on a solution and it makes more sense. But back at that point in time, there was a lot of confusion, and the demands for transparency were like really kind of boiled up very, very quickly and took us by surprise, because we didn't expect this to happen. And we couldn't, it took us a while to try and understand where some of these things were coming from, but it's driven from civil liberties. I think privacy advocates were looking at the idea of an app and contact tracing and the idea of identifying people via this as very problematic from a data perspective. And I think that was kind of the starting point for us, and having to deal with that from very early on, and the external oversight, scrutiny, and the intense kind of focus that people put on it pretty much throughout this entire process, which is only going, and just to give people a sense of it, it's like this started on the 18th of March, well, actually the 17th of March, which is St. Patrick's Day, and running up to go live on the 6th of July. So that's kind of the time frame that we're talking about. So it was very, very compressed.
Yeah, it was a bit of a sprint, but on the other hand, it kept us busy, which was really great. I was grateful for personally. Um, okay, so I know that we used a decentralized architecture. We finally landed at that. Can you talk a little bit about the implications of architecture?
Sure. And this is one of those things, and again, it became this meme that just floated around the place, that that centralized versus decentralized, and all of a sudden, people became authoritative voices in this space. So, if we take a step back from this, from a public health perspective, a public health response to any pandemic or any outbreak involves, and even the legislation and the regulations surrounding it, all involve the identification of an index patient and then the tracing of contacts who you suspect would be infected with this disease. And it's all around the limitation of that.
Mhm.
And everything is designed around that. So it's designed with the identity of that individual in mind. And how public health professionals and epidemiologists think about it is with that in mind, with an index patient. And the centralized model, so if you talk to, if you go and look for, in a classic way, and look for requirements from a public health body or from public health professionals, they will tell you, we need to understand who the index patient is, we need to understand who the contacts are. And that leads you down the road of building this centralized model of, I identify you, I identify who you're in contact with, I can connect those pieces of information together, I can share it with the health authority, and they can intervene, get people tested, isolate, whatever else needs to be done to deal with that and to deal with outbreaks. The decentralized model, on the other hand, is coming very much from a different place, because it's coming from the privacy preserving. So if I'm going to do this kind of work at scale, and I'm going to scale this out to a population, then all of a sudden I've got this population effect where I'm now dealing with the data from everybody, or as many people as possible as I can get on to use this platform. That creates other problems. So now I've got this massive information that kind of gets aggregated into one place, where I'm connecting people together and identifying social graphs, which is perfect, seems to be perfectly acceptable if I'm using a social network, but seems problematic when a government undertakes it.
Right.
And again, it does boil back to the relationship and trust relationship of the government with its citizens. And it's in different countries, it's accepted, in other countries, it's not. So in Singapore and Australia at the moment, it's a and in France as well, it's a centralized app, right? So they've
Mhm.
got a centralized infrastructure and they're up and running. From a public health perspective, not problematic at all, but it does create privacy issues. The decentralized model is, it's a real it's a journey for public health people to kind of to understand how this can even possibly work. So
Mhm.
as we went through this process, we came and we were building a centralized app, and we were looking and mirroring what the guys in Singapore, the Trace Together app, what they had done initially. And we talked to Jason Bay and his team. We were working through this process. It became clear to us that we wouldn't be able to to deliver an app that was stable and reliable, because there were issues with background processing of Bluetooth, and there were a bunch of other technical issues that were going to make the delivery of a reliable app very difficult and very problematic. And we had kind of engaged a lot of really hardcore engineering work that Nearform were involved in, and Fiac and Colin and the other guys really worked really hard to try and figure out ways of doing this, talking to Apple, trying to figure out, can we do it? Are there ways of working around this? Working with the with the Germans, with the UK, with other countries to try and figure out how we would do it. So it was a giant collaborative effort to try and fix it. But once we decided that we were going to go with the Google Apple exposure notification system, that flipped. And that meant that we had to go back to the public health people and say, hey, so you know the way we said you'd have an index patient. So now you
Right.
don't. And then there's a moment where they don't think they've heard right what actually happened. And everything kind of slows down for a second. And we walk them through the process, and we walk them through what data we have versus what data we don't have, what we can do versus and what we can't do anymore. So it does change the way everything is approached, because everything else up until that point is designed around it. So existing contact tracing tests somebody, gets a positive test result, they become the index patient, traces contacts. So
Mm.
now all of a sudden I'm going to have these events that pop up where somebody pops up as a contact, and I won't know where they are, who they are, or what happened, right? Or who they were in contact with. And that really took a while. And I think for anybody engaging in this, there is a journey here to bring them on that road to
Right.
understand now what's possible.
So
And
that means our data set is super small then.
this is like, of anything I've ever worked on, this has the smallest amount of data. People talk about data minimization. This is data minimization in the extreme.
Yeah, it's
We
very
haven't
elegant.
started
I
with,
know.
it's
It's
nothing and work up, as opposed to start with everything I want and work down, which is usually the reductionist way that we go about it. Here's all the data I would love to
right.
have, and I start there. We started with, we don't know anything, what can we know? As opposed to, we could know everything, what are we allowed to know? So it did
So
shape the way we went about it.
what actually do we know? What does the data actually tell us?
So I guess we've got two sides to that. So when somebody goes, so there's a few different paths through if you want to use the app. So in the onboarding process, I can be completely anonymous. I can provide no information to the HSE at all. And it allows me to get up, activate the exposure notification system, and receive notifications should I come into contact with somebody who's tested positive for COVID-19. So that's one piece. In that instance, we have zero information. We don't know that you're on board on the app. All we can see is that there is an App Store download number, which is an aggregation of things to say an app was downloaded, right? Or a number of people have downloaded apps from the App Store. But that's the only piece of information we have there. If I work up from there, you can provide and enable us to capture metrics. And the metrics tell us how many people have onboarded, how many people are active, how many people have the system activated, so we know what the level of coverage is at a national level.
But the person who downloaded the app gets to choose if they want to give you that data.
100%. And so literally everything that's in this is all opt-in and all configurable. And the basis for collection of the data, and I think different jurisdictions have approached this differently. In Ireland, we went with from a health perspective is the weakest form. So we went with consent. So consent allows anybody to opt in. So it's optional, it's voluntary, it's opt in, and I can also withdraw consent. So it completely puts the I guess everything into the hands of the person, into the hands of the user. So whatever they want to give us, they give us, but it's purely based on consent, and they can also withdraw that consent. And we had done our best to implement the ability to be forgotten into the app. So there is a leave feature in the app, and the leave feature allows you to leave, and you're gone, and we've forgotten about you, right? So you're out of the system unless you have popped up in via testing or via some other piece of contact tracing. You're gone, right? So, and that's the thing.
It's GDPR like then.
We were looking at that, and like, so each and everything. So people talk about privacy by design, and this is probably the first thing I've ever worked on which really truly embodied the principles underpinning privacy by design. So literally every piece of data we went to collect, every feature we went to build, it was looked at first and foremost through that lens of data protection and privacy.
So it's possible for us to make the phone call happen.
So I guess that's the next stage up, is that we implemented the ability for somebody to put a phone number in as part of the onboarding process or via settings at a later stage. And it was really originally with a view to, it was trying to support people who were in at-risk age categories or had underlying health conditions. So that was kind of the primary reason. So people who would actively need support. And there was a great body of the worried well, they were described, I think, in the media as, and the worried well were people who were constantly, like, anytime they got a scratchy throat, they thought, that's it, I've got COVID.
Yeah, in the middle of allergy season.
In the middle of allergy season. So we added the ability to put the phone number in. That phone number stayed in the app and was only released and only sent to the HSE if you got a close contact notification, to allow us to call back and actively participate in your care. Actively, and that's kind of part and parcel of this. And I think that's one of the difficulties with it's trying to fulfill the role as, so the health, like the HSE, so the Health Service Executive is responsible for delivering care to people in Ireland, right, and providing the care infrastructure in order for that to happen. And if you then build an app and push it out and don't provide the ability for people to actually opt in to receive that care, you're kind of denying them something that they have a right to, and something that they're paying taxes for.
Right.
So this gave people the ability to decide, do I want the HSE to actively participate in my care? And we've had a very significant proportion of people who onboard onto the app have provided a phone number. So that would suggest that the overall trust in the system is very high, in that they're willing to provide a phone number and to trust that we will call them back and to participate and take care of them should they have a close contact event, get them tested, deal with them if they develop symptoms, care for them, treat them, and do all of the things that happen. And they're all things that happen in the course of the existing testing and contact tracing system, and this just extends it. And all this app is doing is augmenting an existing system, so it's adding another piece to it. And I think that's another bit that's really critical to kind of bring to
people looking to implement this app need to also implement a system to catch the data and do something with it.
Yes, and I think that it actually brings us back to something that we kind of touched on. We've touched on in previous conversations. So there was research done out of Imperial College in Oxford, And it was one of the numbers that was bandied around in the media, was the 60% number. You need to have 60% adoption or this isn't worthwhile. And actually what the paper said was, if all you did was have an app, you need 60%. But if you've got testing and contact tracing and movement restrictions and hand hygiene and like
Good
oral
education.
nasal hygiene
Right.
education programs, then it's a complex, like it's the interweaving of all of these different things. So you can't point to the app and say the app is successful. The system is successful. And contact tracing is, if you just take the contact tracing is a systemic thing. So it's all aspects of it. It's not just the app aspect. And I think that's the one thing to note, is that if you haven't got the infrastructure to do testing, and if you haven't got the infrastructure to do contact tracing, and you're solely dependent on this, then that's going to require you to have a higher penetration in terms of higher adoption rates.
Right.
If you have, so for us in Germany, we have the testing capacity and we have the contact tracing infrastructure in place. It was painful to put it in place, but it's there now. So now we can use it and leverage it. And the app acts to augment the existing pieces that are in place. And it's just feeding into that. So when we do it, this is a fully integrated. So ourselves and Denmark, I think, are the first two countries to fully integrate end to end, from testing through to the call to the individual to contact tracing and out the other end. So all of the interactions are fed back in, and there's a team that are handling that, and there's public health people that are working on an ongoing basis to both uh, look at the overall system in terms of how it's flowing, the results and data coming back out of that, and then the outcomes that we get from it. So what outcomes are we getting out of the back of testing and tracing?
I would like to say that I really appreciate having been in the pandemic here.
I think so. When we look elsewhere, I think it's
Yeah,
quite comforting that that we've put this in place, and it's now infrastructure that will support us, because it's not like this is disappearing tomorrow. Like this is
right.
something that we're
No,
going
it's
to
going to be a
have to live with.
while.
Yeah,
And I think that my sense is that Irish people value their freedom just as much as any other culture, but they can see and they trust the advice that they're getting is going to lead to better outcomes for their lives. That's what it looks like to me.
it does. And I think we've had some interesting feedback so far from app users. And so we had presented, so the app does three things. So it does the core contact tracing piece and does that. There's a very lightweight symptom tracker, which is focused on the core COVID symptoms. So cold, flu, difficulty breathing, loss of sense of taste or smell. So it asks those questions. That was added as an aid memoir for people to help them remember, because as part of any contact tracing interview or any interview to do with COVID, you get asked, when did your symptoms start? And most people can't remember. And they
Right.
can't remember which symptoms and on what day. And those dates turn into really important dates from the point of view of understanding the isolation period, understanding when this began, understanding at what point I begin the contact tracing process, because it's symptom onset minus 48 hours is the window that's applied from a public health uh, perspective in Ireland. The other thing we did was provide the headline statistics that we were all morbidly fascinated with back in April. So on when you open the app, you're presented with kind of the overall totals, and the amount of the amount of feedback we receive where people are fascinated by this data, and they want more data, and they
Yeah.
want more temporal data. So
People
tell
want
us
to
how
doom
far.
scroll right now. They really do.
Yeah, but they're using it for planning for where will I go in the country? Like
Yeah.
where are there outbreaks? What's happened in the past couple of weeks? They're thinking about that and using data to make decisions in terms of how they respond personally to the pandemic, which is a really interesting one that we've seen kind of in direct feedback, both via the App Store, Play Store, and into HSE Digital. We're getting inbound from people going, "Can you do this? Can you give us more data?" Which is
Right. Well,
really
and the fact
interesting
that you're
to
listening to your customers and empowering them is amazing. So, so back to the data.
yeah.
I know that we can do the phone call. What else can we do with the data?
So I guess that's one of the interesting things, that when you've got this all linked in together, so we know when somebody tests positive, they're then asked to upload the diagnosis keys from the Google Apple exposure notification system. We know that they've been asked. We don't know who's uploaded, but we know keys have been uploaded into our registry. We know they get distributed. So we have all these data points of specific events that happen. We don't know who, we don't know where, but we know that these things have happened. If you have provided a phone number, it generates a message and sends it. So we see uh, a relationship between um, people uploading keys, and we see information being generated in terms of contact events. Again, we don't know who, we don't know where, but we know that somebody has come into contact with somebody who's had COVID-19. Equally, we have, for anybody who's chosen not to share a phone number, we're getting inbound calls now looking to get tested. So we also have a call center that's fielding inbound calls that come in, and it feeds into the same back-end process. So we get a good sense of what's actually going on, how many notifications have been generated as a metric, how many people have received a follow-on call, how many people have called inbound. So you get a sense of what's going on, and at very low levels, and it's important to say we're at really low levels of COVID at the moment. So it's into tens of cases per day, right? So I think we had 0, yes, and long may that last. But so we've had, I think the highest in the past couple of days has been up to 26. And so you see these spikes. There is a relationship between the number of people using the app and the number of people who test positive and uploading keys and the number of notifications that we get. And in terms of tuning and understanding the performance of the system, that's the data that over time, as we build this data set, as it gets bigger, we can begin to forecast, we can begin to see how sensitive it is and how well it's working. And that's really the starting point. So we're founding a research group through Science Foundation Ireland, which is focused on looking at the risk modeling piece of this. And this is to try and really bring more sophistication, because when this started, this is time and distance. So 2 meters,
Right.
15 minutes. As we begin to layer it in, we bring in days like symptom onset date, and the fact that you're not equally infectious over the course of it. So as it goes through,
Right.
you have this window beforehand where you're highly infectious and you're shedding. So there's a lot of viral shedding. You have a window just afterwards, and it looks like that the strength of the symptoms determines your ability to shed as well. So there are other data points that we're beginning to look at in terms of how we bring them in, and that gives us more sophistication in terms of the risk scoring and the risk calculation, which makes it so it moves away from being the crude time distance piece into a more sophisticated, nuanced way of doing the calculation and risk modeling associated with that. So we've got a team of public health, epidemiology, and data scientists who are working on that, but also feeding into other internet. So MIT PACT are working on things, DP3T are working on it. So there's a bunch of international initiatives going on, and each country that's up, we're all sharing data to try and figure out how we can help each other and looking at techniques that we could apply to try and make this better. So I think this, over the course of the next 6 to 12 months, the data that we gather and the way we refine these models is going to massively change the way this works, and will turn into it will really improve the accuracy of all of this overall in terms of how we can support people and how do we give them feedback and let them know what's happening.
Well, then how do you know where and when to deploy the vaccine if there ever is one? I mean, all of that stuff, right?
Yes, yeah. And again,
Cool.
it's
Now,
back
what
to another measure.
what can't you do with it?
So identification of hotspots, which is a classic one from a classic public health perspective, is finding somebody, knowing where they are. And so there's a restriction. So if you're going to use the Google Apple exposure notification system, your app can't use GPS, so it can't use location. And in our original app, we were using GPS. This is when we're building a centralized one. We were using Bluetooth, but we used GPS, but we did it at a quite a crude level. So it was to one decimal place, which is about 1.1 kilometers squared. So we could get it down to a general area. And we were looking at like how useful was that. So in the centralized model, you could identify, so somebody's tested positive and there's a bunch of contacts, and those contacts have happened in this geography. So I can see that happening. In the decentralized model, you don't have the luxury of that. But equally, there are situations where something could happen. So we opened up restrictions on movement. People began to travel down around the country. A bunch of people from different places go and visit or go and meet in one place, and then they jump on buses, jump on trains, jump in cars, and go back to where they came from.
It's a
So
little country.
it is a little country. So you can see things like this kind of happening, and you get, I guess we get information in terms of, we can see the volume of close contact notifications that are being generated, and understanding the relationship and the correlation between the number of positive people and the number of close contact notifications goes to really how sensitive we need to make this system, and how it works. We know from talking to our German colleagues that what they were looking at it from the point of view of, if we have testing capacity, it's better to test than to not test, right?
Hmm.
So in that situation, I can begin to turn the knobs to be able to satisfy that need. If the testing capacity was limited, then you can turn it the other way. So these things are
Right.
all controllable. And I think we spend a lot of time trying to figure out where to set thresholds with relation to the distance. And what it boils down to is it's not just about the distance, it's also about your capacity to deal with something you pick up as a result of something like this. And from a public health perspective, if you're looking at contain, if you're looking at killing something off versus containing it where it's at, like this boils down to epidemiology strategies in terms of what phase the pandemic is at and how you respond to it determines how you use the app in the context of that. So it's not just the app deciding that this is it and it's a binary, it works or it doesn't work. It's actually a systemic piece of what do we want to do in order to limit and contain or reduce or shrink this or kill it off totally. And that really depends. And the epidemiology guys are trying to understand also what's possible with this, because
Hmm.
these are new capabilities that only are available now. They were never thought of before. So I can, like with the API, I can show you or I can give you feedback on your net exposure to all positive people over a 24-hour period, right?
Hmm.
That's not something you could ever ask somebody about.
Yeah.
So, because it turns out that having like 5 minute slots with 5 positive people is equally bad as having one 25-minute slot with one person. So
So
it's the
you're
virus
gonna end
doesn't
up
care.
you're gonna end up with a risk index.
Basically, yeah. So we end up with things like that that are, and this is the future and the roadmap for that. We're working with Google and Apple very closely on the roadmap for where they're going with this, and it's trying to figure out what do we want and what do we do then. And the reason we put that research group together is to try and frame the questions from a public health and epidemiology perspective that the data scientists can answer from the data. And that's the purpose of that, and to justify any decisions we're making with relation to the configuration and deployment of the app. So that's kind of where that works, and that's kind of the next, it's leveling up to the next stage.
Great. So, I'm all about let's make this transparent. So, what you just said is great because it means there'll be academic research papers that can be made available. But of
Yeah.
course, I'm going to want you to make them available in the most transparent possible way. Let's talk about privacy advocates.
I guess from a privacy perspective, so I think I said it at the start. So we were up and running 4 days in, and people are calling for transparency, right? Where we're in the eye of the storm at that point, trying to figure out what was going on and which direction we would go. Those calls for transparency, uh, they that was an ongoing piece, and we were, I guess, until we had kind of uh, converged on something that we were sure we were doing. All right, and sure is a very um, divisive word because we weren't sure. I mean, there was a huge amount of uncertainty throughout this entire
Right.
process as we're trying to figure out things, if they're working, not working, what can we say, what can we not say. And so we had been giving information out. The HSE and the Department of Health are very good at strategic communications, particularly with relation to dealing with criticism in the media or any calls for information. And they provide the information that's required. The problem is that you've got a range of different players in this. So you've got privacy advocates who believe that privacy is a right, and researchers in that area, and they think this is really important, and they look specifically at it through that lens. You also have industry professionals who are operating in this space and want to participate in this somehow, and this gives them a platform to be able to talk about what they offer with relation to privacy, right? So privacy, data protection, things like that. So they're professionals who are practitioners who we could have hired to do something, but we didn't. And
Hmm.
so they have an opinion on this and an opinion on what we should or shouldn't do. And they're very vocal about it and they have active social media followings. So they use this as a platform to talk about privacy. Right, so that's another group. And then there's another group that are more focused on civil liberties and surveillance society overall. So they're kind of three distinct groups, and but we end up talking to them as one body because they end up being converged. And what happens is it gets picked up. The media is looking for mind-sized bites of information that they can feed out.
Right.
So the facts disappear. So the 60% number in terms of you need 60% adoption. Up until post-launch, we had to send out clarifications to all the media outlets to say, here is the research, here's what it said, here are the clarifications. Stop using this number, it's wrong, it's an inaccuracy, you can't use that. Equally with the privacy, on the privacy side of it, there is a trade-off here, and for anybody involved in this, as soon as you do something or concede some ground, the other party, don't expect to have any wins in this. It's a no score draw in that
Right.
all you can hope for is to get through and get out the other end, because anything that you say or do, the external parties claim credit for immediately. We made them do this. So X body forced HSE, DOH to
Yeah,
make this
sometimes you
decision.
just have to say, great, I'm winning. Right.
Exactly. Yeah. So that it was hilarious because like if I look at the centralized decentralized decision, so we boiled down at the end of April, it came down to a decision about do we commit to what we were doing before or do we go with Google and Apple and their solution? And that was a complex decision in that it brought in epidemiology, public health, and other aspects of it. And then on the technology side of it, we had got to the point where we realized that there was no ability for us to deliver a stable product that worked well using anything other than what Google and Apple were proposing. So
Right.
the decision was made on that basis that we can't do this. So this is the only thing we can do. And then it was, is this good enough and does it add enough value in order for us to move forward? As soon as we made that decision to go with decentralized, it was like, yes, we forced you into going decentralized. It was like, okay, if you
Yeah.
want. So I think there's a lot of situations like that where I learned a lot from a communications perspective throughout this process, because it's had such intense scrutiny that you kind of need to just bite your tongue and say nothing and not
Hmm.
expect to come out as a winner in this, because there aren't, like, I mean, the overall winner was last Tuesday when we launched this and we had 1 million people in 48 hours. That justified everything that we had
Right.
done all the way through that process. And I think the other side was publishing both the source code and the data protection impact assessment well in advance of the launch of the app, so people had plenty of time to pore over it. And I think some of the feedback was actually it created this. It's a weird benefit in that it's now set a bar for every other public project, that you guys have done a great job on it, but this is the way all DPIAs should be approached in the future.
Ah, so all
The
your
privacy
future
advocates came
projects
back.
will be run this way then.
Yeah, but actually, it's good in a way because it's actually become a reference. So you can, like most data protection impact assessments, are internal documents that are very technical from a privacy and data protection perspective in terms of
Right.
it's legalistic and regulatory. This was written as a public document, so it had to be very clear. And as a result of that, so anybody could pick it up and read it. You could see what data we were collecting, why we were collecting it, how long we were storing it for, what we were doing. So we had gone through each and every aspect of the app and everything we're doing around that and articulated this in a document. So it's nearly a template it's an example of here's what it should look like, because most people don't know what the end product looks like. So here's an end product that has been heavily scrutinized by lots of people.
Right.
And it was one of those things. And so the guy, Owen Harrison, who was, he worked an awful lot on this project and specifically on that. I've described it as the Michelangelo. He's the Michelangelo of data protection. This is his.
Well, I know when we had our first conversation, a lot of it was on this topic. So, getting it right is, I mean, one of the things that open source has done is it's empowered the question. There's so many more people who understand it all now, and expect to be able to see,
Yeah.
right? Expect to be able to inspect and all that. And now they're going to expect to be able to support or contribute to.
And that is the next piece. And I guess there's another piece as well that it's probably important to note that from a HSE perspective, this is the very first time they've open sourced anything,
Right.
right? So even and so there's an education and a learning process for a large public sector body in understanding what that means and how that works. And the initial call was driven primarily by transparency to say, show us how your code works, right? So
Right.
that was there. That turns into other people. And so obviously we've been sharing with other national health
Other
authorities,
governments, yeah.
other governments, and we've been happily doing that. But now it moves us on to the next piece of actually turning it into something, because we've obviously built something that is it's up, it's running, it's working. We've been successful in terms of our launch. There's a lot of work we can do in terms of sharing our learnings from this, and I
And
guess
it's already found cases, right?
it's yeah. So it's it is up and running. We have people upload diagnosis keys. We've had close contact events have been raised as a result of that, and we'll be publishing more information over this over the next couple of months as we gather more data and track this through and look at outcomes. I think one of the key things in this is that there is a sense now, and it's just to bring it back to the privacy piece that it's we have a time bomb in our DPIA that says this will be decommissioned 90 days after the end of the pandemic, or if it's deemed to be not effective. And so the next call is to show the efficacy of it, but at very low volumes of cases,
Hmm.
the efficacy. And actually, if everybody else does their job and washes their hands and covers their face and wears masks and does all those other things, the need for the app reduces. So the app is there as another, so it has to be seen again at a systemic level. And I think the presence of cases is not success for the app. It's actually it's a societal failure to respond appropriately and to take the right measures and caution and be cautious about these things and maintain social distancing, hand hygiene. Like, it's all of those things play a part. And I think we're going to be held to a standard of, well, how many people have you found? And that's not the answer. So it's interesting to see how this will play out, because this will very much play out in the media, and people will come back in 90 days and say, where are you? What have you found? How is it working? Show me the results.
Right.
If you look at the positivity rates among close contacts, it's not like everybody who comes into close contact with somebody who's tested positive turns into a positive case. It's not a one-to-one. So there's the percentage piece, and then there's sampling and sample size. So I think it's only over time do we see the impact of this. And I think that's going to be the key piece to kind of track it through. But it will be the next battle that we fight in the media in terms of demonstrating and proving efficacy. And it is a challenge.
Yeah. And then there's the one more piece, which is, I know this was stunningly cost effective.
as I'm talking to Nearform, thank you. And the guys in Northern Ireland were equally delighted because the secondary benefit, I think that,
Well, everybody downstream that uses it is going to be delighted.
absolutely, like in comparison, so it was 850,000 euro, right? So that's all in. So that's it.
That's
And
every study, every,
it's
yeah,
it's the testing, the development, the security, the whole lot. And then if you look at it in comparison to other jurisdictions, we've seen into tens of millions have been spent on, and we're all building. And the really fascinating thing is we're all building the same app. Like, so
right,
we're all doing the same thing, building it on the same infrastructure. So, I mean, you've got a choice in terms of everybody's building it on a cloud platform. I think the Germans are building it on a private cloud platform there, but everybody is building it on a cloud-based platform. Everybody's building it with the same Google Apple exposure notification system. Some apps are very little, like, so some apps just do contact tracing, nothing else. Ours does a bit more. And I think it's actually something that, and it's highlighted, because I forgot to mention earlier, the European Data Protection Board had announced that apps should only have one purpose, and that purpose should be contact tracing. And the accusations began immediately of mission creep and purpose. It should be single purpose, and sole purpose should be contact tracing. If you take the technical implementation of digital contact tracing as its purpose, that's a very narrow definition of it. Our definition was that our app is a pandemic response app. So it enables us to respond to the pandemic. So that's the purpose of the app, as defined by the health authority who release it. And our mission is to defeat COVID. So the mission is clear. The purpose of the app is clear. And contact tracing, digital contact tracing, is a feature in the app. And I think we lose something when we begin to narrow it down. So because contact tracing is an invisible, in the same way the virus is invisible, contact tracing is invisible.
right.
So if the app doesn't do anything, then people forget about it. And this was not to get them to use it all the time or to expand its reach, but actually to get them to engage with it and to give them a reason to use, share, and give it some positive benefit. So yeah, so sorry, I just wanted to make that point about the single purpose thing, and I think that's something that was conflated. So what the EDPB said and how it was interpreted they're different things. And so the mission, the purpose, the feature, there are three distinct aspects of it. And people are conflating feature and purpose and saying, well, it's doing more than one purpose. It was like, no, that's like saying if I open like a word processor and file is the purpose of it, like file open is the purpose. It's like that, like that's the sole purpose of it. It can't do anything else, can't do save. Like, it's a crazy concept even to think about it from a technology perspective. It doesn't stack up. But it is one of those things that, as anybody going into this, just eyes wide open, you need to understand that these are some of the things that will pop up, particularly in a European context.
Right, right. So you did add some features that are intended to get people engaged.
Yes, very much so. And they all, but I think the important piece is that they are directly related to COVID-19. It's not like we added another feature which has nothing to do with this.
Mm,
So all the data that we present in the app, which is one of the features, is that it's all related to COVID-19. It's all related to both the use of the app and the progression of the pandemic. So it's a valuable source of information, and it's a direct channel to a citizen to give them other information. So it provides a platform for us to now get to 1.3 million people with useful information that can help them make decisions. So it's a platform then to be able to do that. And
so
that's
it's an
part of the
open government
requirements.
play as well.
Yeah, so we have that ability to do that kind of very specific strategic communication about this one topic to this group of people who have downloaded the app. The symptom tracking again is another one that it's if you separate it out. So we managed to get 1.3 million people to download this app. Imagine trying to get 1.3 million to download two apps, and imagine the confusion that
Right.
would result from that. So doing that, it just seemed like something that because symptoms and symptom data is important, and we're actually, something I didn't mention earlier was that the symptomatic data, we keep 28 days worth. So we keep 14 days worth of contact tracing data. We keep 28 days worth of symptomatic data, and that's a rolling window. That data is bundled up, anonymized, and it's sent to a data hub that Department of Health have called GeoHive. And that's then used to it's an effort at doing syndromic surveillance. So it's looking at the state of the nation in terms of how people are feeling and where they are. And you provide some basic demographic information. So town, county, sex, and age range. It's really coarse grained, and it's intentionally so, again, to preserve your privacy and
Hmm.
to guarantee anonymity, because you can't re-identify. So our age ranges are, I think it's 16 to 40, 40 to 65, and 65 plus. It's that order. So they're very coarse grained. So from an epidemiology perspective, they can't, like, it's like, like they want like five
Right.
year age
Need
bands,
more precision. Right.
and from a location perspective, small statistical areas, which is kind of a couple of hundred houses. That's it, right? But
Mm.
we can't get there. But we do have the ability to at least gather some of this information. And again, it just gives us a platform to be able to capture it, but it helps the individual remember, but it also gives valuable information to health and to the guys who are doing health intelligence to figure out what's going on. And it's another data point. It's not the only, but it's another one.
Cool. Well, thank you so much for talking to me today, Gar, and talking to everybody that's going to watch this. And I know that we're having this conversation to spark a conversation in a working group. So hopefully we've brought up all of the issues and challenges and trade-offs that have to be made, and the things that you can do with a very little amount of data. And I think we've also made the point that we'd be delighted if to see other governments use this app, and in fact, several have already signed up to do so. So, get in touch with us, either with Nearform or with the HSE, and they'll send you in the right direction. And the code is about to be open sourced at the Linux Foundation. It's an open reference implementation now, but we're hoping to build a real open source community around it as well. And so be looking for that. And thank you very much for the Linux Foundation and Nearform and the HSE.
Thanks, Denise. And thanks to everybody for this, and the Linux Foundation for the opportunity to kind of talk about what we've been working on over the past couple of months, which has been incredibly exciting but ultimately incredibly tiring towards the end of it, because we're kind of at the end of a 4 month journey, and I think everybody's
Yeah,
kind
we're
of
definitely at the can I have a nap yet part.
yeah, I'm off next week.
Oh, good man.
Yeah,
All right. Thank you again.
thanks, Denise.